Hi, this is Brian Kim. I'm going to share with you this case of a patient who had an ICL implant, and the case went well and he was doing fine, but it was a little bit on a shallow vault. And so I was watching him for several months and I started to see a little bit of anterior capsular haze. And so we decided to exchange him to the next largest sized lens. So I went online and went on YouTube and looked at the various videos from Star Surgical. And so there's a variety of techniques, and I just want to share some of my thoughts on some of these techniques. So this one is showing the surgeon cutting the lens, and I don't believe this is the right way to go. You don't want that scissor to touch or cut the crystalline lens, and then now you're in big trouble because now this patient who wanted just refractive surgery is now going to have cataract surgery. In this case, the lens is actually horizontal to the incision here, and this person is using these forceps to, and of course those are nice big forceps, takes a nice big grip, but then the lens is going to collapse along the kind of a wider axis, and so again it's perpendicular to the axis, and so I don't really think this is the best maneuver. And then this person is using forceps and pinching the lens inside the eye, and again I don't feel comfortable with that because what if you pinch down on the crystalline lens? And so I prefer most of the maneuvers, if possible, to be outside of the eye if you can. I think this person's getting the idea, and this is the way Star would advocate. You want to gently grasp the corner of the lens, explant the lens out of the incision, and then you want to hand by hand grab the lens and gently pull it out, and then it just kind of folds on itself and it comes out. And so I'm going to show you how I use the technique with a two-handed micro forceps technique. And so this is the new lens that I'm preparing. I'm placing it on the cartridge here, and then using these long forceps to make sure it gets tucked in the platform. And these are the long forceps to pull the lens in. You want to get a nice big bite, and as you pull, your steady pulling force as you go through. You don't want to accidentally tear the lens, and then you want to be a couple of millimeters shy of the opening. I switch hands and I'm pinching the cartridge so that it goes into the injector, and I'm ready to go. I make my right side incision. I'm pointing it up and away from me so it faces towards the haptics, and then the left side I'm making the incision towards me so it gets into subincisional. I'll make another stab incision there. This is intracameral lidocaine, and then some Amvisc viscoelastic, filling the anterior chamber. And this is my 3mm keratome blade. 3mm is a little bit snug, and you'll see that here as I proceed with the case. And then I'm injecting some more viscoelastic underneath the lens. So this is the beginning of the explantation. Very careful. Make sure you don't touch the crystalline lens with any of these maneuvers. Again, I'm visco-lifting that edge of that lens. And once I do that, I'm using micro forceps. These are the serrated IOL holders by MST. And I'm able to grab the edge here. And these are the smooth tip forceps in my right hand. And then I'm using a two-handed technique essentially to be able to find that edge, that corner of that haptic, and then I'm going to pull it out of the wound right there. So again, you can see very controlled. I'm able to find that tip right there. Once I've externalized it, I'm going to get my conj forceps because they're more robust. I'm able to grab it, but you don't want to yank it here because you might rip the tip and then the lens will shrink back in. So you get a nice grip. And then using two conj forceps very carefully, and I'm going hand over hand, I'm going to go ahead and pull that lens out. And you want to make sure the forces are parallel to the iris plane. You're not lifting up as you're doing that because you don't want that lens to touch the crystalline lens. You want to, again, pull parallel to the iris plane, and very slowly, and the lens just collapses on itself and it comes out really nicely. Pushing some more viscoelastic in with cannula, and then I'm going to go in with my new lens. But again, I told you 3mm is a little tight, so I'm just going to widen it a little bit to about 3.2mm. With the barrel down, I'm going to go in. You can see it's a much easier injection now with a 3.2. And again, you want to make sure the injector is fairly flat and more parallel to iris plane. You're not going down like you would with cataract surgery. You're staying fairly flat. And as you do that, the lens opens up really nicely. You can see how symmetrical the lens is coming out. You can see both of the ears on the distal side are coming out symmetrically, and it's coming above the iris plane as it's coming out, and you're just gently tapping. And if you saw that little abrupt movement, sometimes it gets a little stuck, but everything went fine there. I'm going to inject some more viscoelastic on the surface of the lens just to push it down more. And then now we're going to use these manipulators, ICL manipulators. There's different types, and I have both of them, and they both work fine, but I'm going to try to gently tuck the haptic underneath the iris. And because it's quite thin on that edge, as you try to tuck, the lens does kind of bend, and it allows you to kind of push that edge down. And I did it on the distal side. Now I'm going to do it on the proximal side. And I make that extra incision on the left side, but I haven't really used that for the haptic tucking. I felt like I get a really excellent control by using the main incision for both of the haptics here. So it's very well controlled, minimal trauma, minimal manipulation with all of those maneuvers, including the ICL insertion. And then the rest of it's just using BSS to pulse the remainder of the viscoelastic out. Now this is going to be in 4x speed, but the bottom line is you want to get all the viscoelastic out of the anterior chamber, but more importantly, underneath the lens. And sometimes it requires you to go through the paracentesis incision and just kind of pulsing very gently. You should start to see the viscoelastic moving from underneath the ICL and then mobilize and then come out of the anterior chamber, and you just want to burp it out. So again, this is my technique on how I was able to exchange this lens. Again, I think it makes sense to grab the corner of the lens. By doing it that way, it's the thinnest profile coming out. Very important that you have a nice technique in doing that. Some people are doing all sorts of maneuvers to try to get that haptic tip up. But as you saw, using viscoelastic, you're going to visco lift the edge of the lens, and then using microforceps, you can grasp the lens, and then through the main incision, you're able to use a two-handed technique to get that tip of that haptic towards you, and then you can externalize, because that's the problem. If you look at the incision opening, it's more proximal, whereas the haptic tip is much more peripheral. And so that's the key and the trick is trying to get that haptic closer to your incision point. And the only way to easily do that without doing a lot of manipulation, in my opinion, is using a two-handed micro-incision forceps technique. You saw I was able to, through the paracentesis, grab it, and then through the main incision, grab it again. And you can just kind of use a two-handed technique and inch your way towards that corner tip. And then you can, in the main incision, you can pull it out. And once you got it out, that's the hardest part. And then now you can use something like conj forceps, grabbing it, and gently with two-handed technique, inching your way forward, and you're slowly pulling the lens out. Again, you want to stay flat and the force is parallel to the iris plane. And as you pull it, the lens just wants to collapse on itself. And you want to make sure you're parallel to the iris plane because you don't want that lens to be tilting up and down while you're pulling it out. You don't want to hit the cornea. You don't want to hit the crystalline lens. When it collapses out, it just kind of comes together and it pulls out really easily. And then you go ahead and proceed with the replacement with a new lens. This patient did very, very well, and afterward had an excellent vault after surgery, and the patient was very happy. So I hope this was helpful to you, and I thank you for your attention.